minutes each, with 4 minutes of Q&A that will be mediated through chat. With that, let's dive right in. Our first speaker is Young Che, who will be talking about DART and a rare cancer update.
Thank you. Thank you. It's Young Che, Vice Chair for the Early Therapeutics Rare Cancers Committee, one of the study chairs for the DART study team with Dr. Patel and Dr. Kurtrak. It's my honor to present the update on the DART S1609. Next slide, please. These are my disclosures. Next slide, please. So DART is a dual anti-CTLA-4, anti-PD-1 blockade in rare tumors. That's where the acronym comes from. It's the first of its kind phase 2 basket trial funded by NCI. And we noticed that rare cancers as a collective entity is not rare anymore, about 1/4 of the whole cancer that are diagnosed. And we do know that the combination approach can be much more effective than the single agent approach, as you can see in this melanoma trial, as well as other tumors such as lung cancer. Next slide. So the primary objective of this trial is overall response rate. We're using the Simon's two-stage design 6+10. So if you see at least one response from the first 6 patients, you can move on to the next, adding next 10 patients. And if you see equal or more than 2 patients out of 16 patients, it will be considered as meeting the primary endpoint. We're using the IPI 1 mg/kg every 6 weeks plus Nivo fixed dose to 40 milligrams IV to 2-week dose, continued until progression or acceptable toxicity. There's an optional Nivo monotherapy option after 2 years. Next slide. So we first launched as a trial that was married with NCI match, which actually had a lot of initial screen failures where there were patients progressing on match arms. And about 1/4 of the match patients happened to be having rare tumors. Next slide. So it would be such as, feeding the loop with a screen failure or upon progression, automatically making them eligible for the DART trial. So you couldn't go into DART as a standalone trial in the initial phase. Next slide. So this is the history of DART. We had a conception phase in 2015. Finally, in January 2017, our protocol was activated. And then October 2017, we became independent trial with NCI sort of running out of the resources to their in-house sequencing approach. At that time, we started with 33, but became 36 cohort. Next slide. And then we were starting to do serial biomarker translational medicine approach added to our efforts. And then March 2018, we were thankfully granted the CMAC pilot grant to do our immunotherapy monitoring analysis. We had our first presentation for neuroendocrine cohort in April 2019. And then we had a few AACR orals, followed by the SITC oral and poster presentation, which I will be giving you updates on. Next slide. So initially, this is how we started with 33 cohort. As you can see here, what's unique about it is we have histology approach where we have cohorts that are enrolling regardless of site of disease, like cohort 23 neuroendocrine, and we had tumor of unknown primary, cohort number 32, and then we had the not otherwise categorized NOC cohort that became a source of launching into another cohorts, and this was allocated based on our discussion amongst our study chairs. Next slide. So over 2 years, we were able to add 20 different cohorts, and some of them were just from the NOC cohort. And then what's unique is we also have cohort number 50, PD-L1 amplified cohort. This one, we don't look at the histology per se for its rarity, but the PD-L1, the copy number amplification, whether it is a common tumor type or not. And then we have angiosarcoma cohort, which we will be presenting today. We also have a dedicated high-grade neuroendocrine tumor, which is a spin-out from the overall neuroendocrine tumor cohort. Next slide. So this is the accrual report as of today. As you can see, we have a lot of trial cohorts that are now permanently closed, waiting for the final assessment for responses and progression-free survival. Next slide. So we're about more than 2 years out, close to 3 years out from the activation of trial, and we have enrolled about more than 200 patients over less than a year period. Now we have a total of 763 patients enrolled, 38 permanently closed cohort, 6 temporarily closed cohort. This is to assess for the proceeding of the Simon stage 2 design. And now we have 9 open cohorts. I listed them on the right side of the slide. Next slide. So for the translational medicine piece, we started as a match trial for the with NCI match. So some of our samples are stored in the match archive depository. Now we have it in our own SWOG tissue depositories, and these are the CMAC immune monitoring analysis platforms that are listed here. Next slide. So we're not only looking at tissue, but we're looking at 3 different time points to assess the blood biomarkers. Next slide. So this is the CMAC platform. We were allocated to the MD Anderson core, the CMAC 1, and all the data generated from this core will be going to the CIDC at Dana-Farber. So as we speak, we are launching the first set of immune monitoring analysis as we speak. Next slide. So these are the biomarkers that we have launched the projects on, and we have the 2 commercial collaborators, Biodesix and Circulogene, to assess proteomics as well as the ctDNA. Next slide. So I just want to give you a brief update on the previous. So the first update was the cohort 23, non-pancreatic neuroendocrine. We have overall response rate of 44% in high-grade neuroendocrine carcinoma, independent of primary site, versus 0% in low-grade intermediate tumors. It was presented by Dr. Patel and AACR oral and published in Clinical Cancer Research. Next slide. That's 2020. The inflammatory breast cancer cohorts results were presented by Dr. Sylvia Adams. This was in collaboration with ECOG. Overall response rate was 12 by the regular RECIST, but per iRECIST was 18%. Did meet primary endpoint, and these are the waterfall and swimmer plot as you can see on the right side. So for very rare, like 1% of the breast cancer, very aggressive, this is a pretty encouraging result. Next slide. And the salivary gland cohort showed interesting results as well. Overall response of 15% in non-adenoid cystic carcinoma, 5 PR out of 34 evaluable patients. Adenoid cystic showed overall response rate of 4, 1 PR out of 26 evaluable patients. Next slide. And for small bowel, these are MSI stable. Otherwise, they would have gone to receive pembrolizumab monotherapy. Cohort number 5, overall response rate of 9%. CR, 1 patient, 1 PR with durable response over 15 month out of 23 evaluable patients. They're all presented at the AACR oral. Next slide. So at this CISC, we have cohort 51 angiosarcoma and cohort 26 thyroid cancer cohort, oral presented by Dr. Wagner and poster by myself. Next slide. So angiosarcoma, next slide, is also a rare entity and portends very poor survival. And as you can see here, head and neck comprises about 30%. And that has been, next slide, linked with some responses to immunotherapy. But traditionally refractory to many traditional chemo or radiation. Next slide. Next slide. So these are the recent studies that show that subset of the angiosarcoma have high TMB in nature, and some of them have UV exposure signatures. Next slide. Next slide. Yes, next slide. Some common mutation as it increases exposes them to a higher sensitivity to immunotherapy, increasing immunogenicity. Next slide. Next slide. So these are the anecdotal evidences that have been published. There has not been organized clinical trial to test this hypothesis. Next slide. Next slide. So these are the characteristics of the angiosarcoma cohort, median age of 68, good performance status. Next slide. With primary site being most commonly face, scalp, and then breast and liver extremities. Next slide. Toxicity, there's no alarming signs as these are expected as we've seen in other trials with nivolumab. Next slide. So grade 3 toxicities were mostly single digits or less. Next slide. So response rate was 25%. So 4 out of 16 patients showed partial response, as you can see here. And the right side, the red color shows they are from face, scalp. And there's one breast cancer patient. That's actually one of my patients who received radiation to breast before. Next slide.
Actually, Young, with apologies, we have to be brutal on time because we have a really tight schedule. If you'd like, you can jump to your conclusion slide, allow people to ask questions for later answering during chat, and we'll make your slides available. Thank you.
Yes, let's go to the next. Let's just go to the next slide. Next slide. These are, I'll just go jump. Next slide. Next slide. Wish I could control. Next slide. Can you just, next slide. Next slide. So this is the one slide that I, yeah, so thyroid cancer out of, this is, don't have it here. So 12% overall response rate. There were 2 PRs from papillary anaplastic subtype, and then we had 2 additional unconfirmed PR from the papillary subtype. So what is interesting, 1 out of 4 patients with anaplastic thyroid cancer had the response that lasted more than 2 years. So that was sort of like a punchline from the thyroid cancer cohort results. So we can go to the last slide.
Yep.
That's, yeah. Everything else is just progression-free survival, overall survival. Which I could control. All right, so the safety update is angiosarcoma, overall survival of 25%, 4 out of 16 PRs. Thyroid cancer, 12% overall response, 2 out of 17 PRs, including 1 in anaplastic unconfirmed PR, and 2 out of 4 had PFS greater than 12 months in rare aggressive anaplastic thyroid carcinoma. So that was 2 big updates we have for you from the DART. Thank you.
First of all, Young, thank you so much. Congratulations. Sorry to be so tough on time. And again, if conference attendees can get questions through chat, we'll try to get to them later. We're going to move on to David Feldman, who will be presenting some incredibly interesting results from a hopefulness survey.
Sure. Hello. Thanks for having me here today to present one of a few different studies that we're doing under the auspices of the Palliative Care and End-of-Life Care Committee. And we're sort of in that group studying a couple of different things. Some of our studies concern hopefulness in patients. Some of our studies concern hopefulness in providers, in us. And so that's what I'm going to be presenting to you today, a hopefulness survey of SWOG members and providers. And particularly, we're going to be zooming in on the relationships between hope, job stress, and burnout. Go ahead and hit next. Hit next one more time for me. Okay, so I don't think it's a hard sell to say that patients care about hope, but it's probably a little more counterintuitive to think about hope as it applies to us, to healthcare professionals. And one way of thinking about this is the relationship between hopefulness, or lack thereof, and burnout. So we all know through the research and through our own experience that burnout is a major problem among healthcare professionals, physicians, nurses, particularly in the oncology space, skyrocketing rates of burnout. And I'm even talking about pre-COVID, these rates were skyrocketing. Also, skyrocketing rates of depression, and also pretty low rates of general life satisfaction and well-being, according to some research in physicians. And one way to think about this is that hope is actually the opposite of burnout. In fact, one way of thinking about burnout is that it is actually hopelessness, that your efforts amount to anything in a work context. So I think it's really important for us to investigate a little bit more how hope works for providers. Hit next once. Of course, whenever we're talking about hope, we have to carefully operationalize and measure it. There is a model of hopefulness that's been around for about 30 years in the social science literature, mostly the psychology literature, called the hope theory model, and it has birthed a number of valid, reliable, quantitative self-report measures, including the adult hope scale, which we'll be using in the research today. Hit next once. And that model, that hope theory model, defines hope as having 3 interrelated components. And just briefly, the first of those is having something to hope for. So goals. And I think in a healthcare context, we tend to jump to the conclusion when we hear the word hope that we're talking about goals for cure or life prolongation, hope for cure. But in fact, goals can be in any area of your life for anything that you want to get, do, be, experience, accomplish. The second condition or component of hope is pathways. Pathways basically means the perception that there is a way, a strategy, a plan that will get you to those goals. And then the third component of hopefulness is agency, which is basically another word for motivation. The motivation to actually put those pathways into action. So the combination of goals, pathways, and agency is how we're defining and measuring hopefulness. Next slide. So this figure appeared in a fairly recent article, The Science of Hope, in September in Lancet Oncology. It was published by myself and my colleagues, Dr. Korn and Wexler. And in this article, we reviewed the 30+ years of research looking at the causes and consequences of hope. And I'll just briefly summarize a little bit of that here. In patients who are physically, or in people, I should say, who are physically healthy, at least, we find that higher hope is related to lower depression, lower anxiety, higher levels of general satisfaction in life and well-being, which is going to be important in the present research. In patients with chronic pain conditions, we find that higher hope is related to better pain coping and better functioning in various areas of life. Hope is also related to health behaviors like diet and exercise. So lots of reasons to think that hope is related to really important health outcomes. Next, please. But of course, most of this research was done in patients. What about in healthcare professionals? And that's really where the SWOG member survey comes in. So we surveyed 1,000 members of SWOG, could have been some of you, online. 226 surveys were completed. And that's, by the way, about on par with what you see the response rate being in other surveys of similar professional organizations and guilds. There were 50 items in our survey, and here are the actual questionnaires. We had a basic demographics survey, the adult hope scale, which I mentioned before. The satisfaction with life scale is a general measure of well-being in life. We had measures of job stress and burnout, which are very important here. And these are both single item measures. And then finally, we also measured perceived social support. And the reason we did that is that past research shows that there are relationships between social support, whether that's from friends or family, and lower rates of burnout and higher levels of general satisfaction and well-being in life. So social support was important to include here. Next, please. So here's the breakdown of our sample, and you can see the two largest groups in our sample were physicians and RNs. We also had a fairly large group that we're calling other, which is just a heterogeneous group of other professions represented in SWOG. Next. In our sample, mean job stress was pretty high, 3.6 out of 5. Next, please. Burnout was a little bit lower, 2.77, and I think this should still give us pause. You know, in our sample, we're seeing at least moderate levels on average of burnout. And by the way, this was just pre-COVID. This was like the month before COVID really hit. So you can only imagine that the levels of burnout would be much higher now. Next, please. So let's look at the model, the hypothesized model we're actually testing. So what are we actually hypothesizing here? Well, we wanted to use a fairly complex statistical approach to understand the relationships between all of these variables you see on the screen here. And we wanted to use this fairly complex way of modeling because past research, by and large, had only really examined 2 of these variables at a time. For instance, the relationship between job stress and burnout. But of course, things like burnout and life satisfaction are probably multifactorial in their determinants. And so it's really important that we model all of this together in a single statistical approach. So let's actually look at the results that we found. Hit next once. So I'm just going to rearrange this to make it look prettier. And here are the actual results. And you can see that they coincide pretty well with a hypothesized model. And I just want to highlight the most important relationship here, which is this relationship between hope and life satisfaction, very robust. I'll spare you most of the statistical details, but as you can see, indeed, hope is mediating the relationship between burnout and life satisfaction. Hope is also mediating the relationship between social support and life satisfaction. Hit next once more. And I just want to point out one relationship that we did not find in the current data. We did not find a direct relationship between job stress and life satisfaction. And I think that should strike us as a little counterintuitive, and we're not the only study to find this. I mean, in our own lives, when we have low satisfaction, low well-being, we often go thinking, well, how can I reduce my job stress? But according to our data, that's maybe not the right way to think, because hopefulness, or lack thereof, is actually mediating that relationship. Hit next. So what are the implications here? Well, our results suggest that hope may mitigate the effects of burnout. And, you know, this is cross-sectional research, but if you'll permit me to speculate causally for a moment, the combination of hope and social support may prove useful for actually reducing burnout and improving life satisfaction. And luckily, single session hope enhancement interventions already exist. And some of these have been produced by myself and some of my colleagues. And these incorporate both elements of hope and social support, both of which in this study were shown to relate to life satisfaction. And we've used these with patients, we've used them with non-healthcare professionals, and we're currently constructing an online version complete with an app that we're going to begin to pilot with healthcare professionals, including some people hopefully from SWOG. So stay tuned for that. Thank you very much for your attention.
David, thank you so much. That was fabulous. I don't see any questions in chat. I think we do have Dr. Bakaitis with us. But if nobody wants to post one, we'll just ask you folks to get them in later, and we'll try and get back to them, and we'll move on to our next speaker. Next, we have Dr. Kevin Kalinsky, who will be talking about one of our most exciting findings through our research network this year, the results of S1007. Kevin?
Hi, everybody. Thank you for the opportunity to present these data. So we presented this at San Antonio back in December. This is the responder study, and we're presenting the first results from this trial. And it's my pleasure and honor to present this on behalf of co-investigators and SWOG colleagues. Next slide. These are my disclosures. Next slide. So the clinical utility of the 21-gene Oncotype DX recurrence score has been well established in patients with hormone receptor positive and HER2 negative breast cancer with lymph node negative disease. Next slide. Move forward. So from the TAILORx trial, we saw in patients with lymph node negative breast cancer that age, in an exploratory analysis, that there's a differential chemotherapy benefit based upon age. Next. It's been unclear whether the results from TAILORx can be extrapolated to patients with lymph node positive breast cancer. Next. And so an important study, SWOG S8814, in this particular study, there was a retrospective analysis looking at the role of the recurrence score, and there was a suggestion that this could be predictive in determining chemotherapy benefit in post-menopausal patients with lymph node positive breast cancer. Next. This is the schema. So women age 18 years or older who had ER and or PR positive, HER2 negative breast cancer with 1 to 3 lymph nodes involved without distant metastasis were eligible. And patients must have been able to receive a second or third generation regimen with a taxane and or anthracycline. And axillary staging by sentinel lymph node biopsy or axillary lymph node dissection must have been done. If patients had a recurrence score of greater than 25, they were off study and recommended to receive chemotherapy followed by endocrine therapy. If the recurrence score was 0 to 25, 5,000 patients were randomized to chemotherapy followed by endocrine therapy versus endocrine therapy alone. Next. The primary objective was to determine the effect of chemotherapy on invasive disease-free survival in patients with 1 to 3 positive lymph nodes and a recurrence score of 25 or less, and to assess whether the effect depends on the recurrence score, with the hypothesis being that chemotherapy benefit will increase as the recurrence score increases from 0 to 25. Next. So there were several pre-specified interim analyses, and on the third analysis, the decision was made by the independent DSMC as well as the National Cancer Institute to report the data. Next. And secondary endpoints include overall survival, which I'll present in just a moment. Next. So of the patients who were randomized to receive chemotherapy, 50% received taxotere and Cytoxan for 4 or 6 cycles. And for the patients who were premenopausal, in terms of the utilization of ovarian function suppression, when you're looking at 6 months post-randomization, 16% of those in the endocrine therapy arm and 3% in the chemotherapy followed by endocrine therapy arm received ovarian function suppression. Next. The majority of patients were non-Hispanic white. Next. A third were premenopausal. Next. 57% had a recurrence score of 14 to 25. Next. And 65% had 1 node involved. It may be hard to see here, but only 9% of patients had 3 nodes involved. Next. And 65% of patients had grade 2 tumor. Only 10% had high grade tumors. Next. So if you look at the overall population by treatment arm, you can see that there was a 5-year IDFS absolute difference of 1.4% for those patients, favoring those patients who received chemotherapy followed by endocrine therapy. That absolute difference, again, being 1.4%, with 54% of the expected events of the final analysis, and the median follow-up thus far is 5.1 years. Next. But what really prompted these data being reported was that in a pre-specified analysis, there was a statistically significant interaction between chemotherapy and menopausal status. That's chemotherapy benefit for IDFS is different depending upon menopausal status. Next. So these are just looking at the characteristics. I just want to highlight that numerically, there was a slightly higher rate of patients who were premenopausal who had a recurrence score of 14 to 25. Again, a third of patients were premenopausal. Next. So if you look at the patients who were postmenopausal, there was no statistically significant IDFS difference. You can see that those lines fully superimpose. Next. However, for premenopausal patients, there was a 5-year IDFS absolute difference of 5.2% favoring those who received chemotherapy with a p-value of 0.0004. Next. So we did look at what exactly was the first event, and you can see for postmenopausal patients, only 27% of those were distant events, and there was no numeric difference between those who received chemotherapy versus those that were not randomized to receive chemotherapy. And if you look at the premenopausal subgroup, 54% of those were distant events as the first site. And numerically speaking, there was a 2.9% absolute difference as that being the first site of disease, with that rate being higher in those patients who received endocrine therapy, were randomized to receive endocrine therapy alone. Next. So if you look at the forest plots, there were no subgroup of patients who were postmenopausal for whom there seemed to be the benefit of adding chemotherapy. Next. And this is different than the premenopausal subgroup in that all groups seem to benefit from the addition of chemotherapy. Next. A third of patients were age 50 or over, and you can see that hazard ratio numerically is a little bit higher than the other categories, but there was no statistically significant interaction term. Next. So if you look at IDFS when stratified by recurrence score and menopausal status, recurrence score 0 to 13 or 14 to 25, in the postmenopausal group, there was no statistically significant IDFS difference. Next. However, for the premenopausal group, for those patients who had recurrence score 0 to 13, there was a 3.9% difference. In those who had recurrence score 14 to 25, it was numerically higher at 6.2%. And this, even though the hazard ratios are similar between the two categories, the risk is higher in those patients who have recurrence score 14 to 25, which is why we're seeing numerically a higher absolute difference. Next. And then in terms of overall survival, there was no statistically significant OS benefit for the postmenopausal patients. For premenopausal patients at 5 years, there was an absolute difference of 1.3% with a hazard ratio of 0.47. If you look at breast cancer specific events, that hazard ratio remains the same. Next. So in conclusion, at this interim analysis, again, we're only 54% of anticipated IDFS events in the overall population. The 21 gene recurrence score 0 to 25 was prognostic, but did not show a treatment interaction with chemotherapy. And we didn't really go into those just given the limited time that we have, but I'm happy to answer some questions about this. Next. Postmenopausal women with recurrence score 0 to 25 did not benefit from adjuvant chemotherapy in any subgroup, and premenopausal women with recurrence score 0 to 25 did have benefit from the addition of chemotherapy to endocrine therapy, with a 46% decrease in IDFS events, and benefit was seen, as I mentioned, in the forest plots across premenopausal subgroups, and there was a 53% decrease in deaths, translating to a 5-year overall survival absolute improvement of 1.3%. And last slide is next. Oh, and we're doing additional follow-up in future analyses, include quality of life and other outcomes. Next. So in summary, postmenopausal women with 1 to 3 positive nodes and recurrence score 0 to 25 can likely safely forgo adjuvant chemotherapy without compromising IDFS, which, if we think about our patients in the US, this could save, thousands of women a year from not needing chemotherapy and all of the associated toxicities and risks with that particular treatment. And then premenopausal women with positive nodes and recurrence score 0 to 25 likely benefit significantly from chemotherapy. Thank you.
you so much. We do have some time, and I'll turn it over to Dr. Pushtai to moderate the Q&A.
So we have one question that I see in the chat, and that's what's the status of the manuscript?
Yeah,
So,
that's
Kevin, I think that's an appropriate question for you.
Yeah, that is an outstanding question. So, this is ongoing at this time.
Lahaus, do you mind take the chair's prerogative and ask a question that I was asked by the NCI? I don't think it was ill-intended, but do you believe the early release and analysis in any way affects the validity of the conclusions?
Yeah.
Go ahead.
Please.
Oh, yeah. I mean, I think that, the benefit that we see from the addition of chemotherapy is something that we usually see within the first few years. And if you look at the postmenopausal curves, those lines fully superimpose. So, I think with additional follow-up, it will be interesting to see whether, for instance, in the premenopausal subgroup, whether, we see some differences, in some of the particular subgroups. But I think the overall finding that we're seeing, I think we will continue to see with additional follow-up.
So I guess there are two questions here. So the one that Kevin answered is really whether the results will change with longer follow-up. And that's not likely because the median follow-up actually is already 5 years. So that's a pretty long follow-up, even though in ER-positive disease, indeed, events could accumulate later. But the curves in the postmenopausal woman, which are the large population, right? It's 3,000 patients, 1,500 in each group. Is really the hazard ratio is 0.97. So it's extremely unlikely that a clinically meaningful change in these hazard ratios would materialize with longer follow-up. The other question that is embedded in this is whether the early release will impact the validity or the integrity of the study. And it doesn't, because everybody completed treatment, right? So the assigned treatments have been completed. And so it doesn't sort of invalidate the original sort of randomized arms.
Fantastic. We're going to move on, but I see that there are some other questions in chat. Perhaps Dr. Kalinske can answer them because they seem to be very important. Again, I want to thank both of you. We're going to move on to Dr. Michael Overman, both a small bowel and large bowel expert, who will be discussing the results of S1610, NRG 60, or that might be a GI 104. Thank you.
Thank you. Appreciate the opportunity to talk to you today about where we stand with the SWOG 1610 NRG GI 004 collaboration study. This is more of a little bit of an update of adjustments to the study and putting into context of how we currently practice. The mismatch repair deficiency, or MSI high space, has seen a lot of changes kind of recently, with a lot of impactful data that's come out and changed our practice. And so I think that was the reason to kind of bring that to the forefront and discuss kind of the changes that's occurring in this study. And so this is the study here. It's led by myself and Kyle Rocha-Lima. And you can see here that the study is a phase 3 randomized study, and initially was designed as a 3-arm study, but has been adjusted to kind of a 2-arm based study. And we can go to the next slide. And so the data set that I think is really kind of pertinent that's come out was the Keynote 177 clinical trial. And so this was actually recently published in the New England Journal of Medicine 2 months ago, and was actually presented as a plenary at this past ASCO meeting. And this was really asking the real fundamental kind of great question of immune therapy, single agent pembrolizumab versus chemotherapy in frontline for metastatic colorectal cancer patients that were MSI high or deficient in mismatch repair. And so really kind of saying, is immune therapy the best therapy for these patients? And this was a positive study, as shown here. You can see that the pembrolizumab arm in green or teal performed better overall, with kind of a robust difference in regards to kind of median differences, and in regards to kind of the outcome that I think is most of interest, is that delayed progression, a longer follow-up. So the 24 months kind of progression-free survival rate is 50% in the pembrolizumab arm versus 20% in the chemotherapy arm, and so really does make the statement that for this type of tumor, We're talking here colorectal, though there are MSI tumors and other disease types. But for colorectal cancer, immune therapy is really the kind of optimal based approach. So we go to the next slide. And so based on that, this study has iterated, and so we are now actually moving to a two-arm design. The initial design of this study was predicated on potentially the results of the Keynote 177 study impacting this study. So this was in part planned, in which we are now iterating so that we have an atezolizumab as the PD-1, PD-L1 standard of care arm, you might say, comparison to a chemotherapy combined with here atezolizumab at PD-L1 as the intervention arm. We go to the next slide. And so the reasons that I think this is still a really interesting and kind of exciting space is that fundamentally we do think that with immune therapy in this disease type, again, microsatellite instability high or deficient mismatch repair colorectal cancer is a unique genomic type of cancer, high mutation rate, very immune responses. We've seen the prior data sets, and those immune responses appear to be very durable. So the data for that is still being accumulated, but we do see consistency in regards to the flattening of these progression-free survival curves, really suggesting that there probably is a cure rate within this group. And so the idea of, can really increase this cure rate is a really relevant fundamental question that we'd like to do. And so the challenges that did come out of the question of the pembrolizumab study that I showed you are kind of listed here with the circles, where you do see actually a worsening for that arm initially in the first 6 months. And you do see a rate of 30% or about a third of patients that actually have progression as their best response. So clearly a good therapy, but not a therapy that's benefiting all these patients. And so next slide. And this is a feature that we've seen across multiple different data sets. And I show you these multiple different data sets that led up. These are all single arm data sets looking at nivolumab or pembrolizumab in the context of deficient repair MSI high colorectal and even some non-colorectal cancers here. And I think the point to be made here is that similarities across all of these, but really that progression rate. So there is a consistent group of patients that are not benefiting from this therapy. And I think the question we're kind of moving into is really how do we actually increase that rate of patients that are benefiting, and this progressive disease rate are really patients that are not benefiting out of the gate. So next slide. And so what this kind of predicated on is the idea that this early progression rate is one that we'd like to address. And so that's kind of the idea of a combination chemotherapy with PD-1, PD-L1 based therapy. We see that in other tumor types where we do have synergism between chemotherapy and immune therapy. And there's clear actually potential for synergism related to the anti-VEGF related component, which is a standard of care within the colorectal space. And so the hope of this study now looking at the comparison of monotherapy of PD-1, PD-L1 versus chemo and PD-L1 is really that we actually would see a shifting of these curves and actually be able to negate this initial progression rate and not have that concern of patients presenting with extensive disease and not getting a benefit from the initial therapy. And so the next slide. And so what this upcoming protocol amendment change does is listed here. And I think this is currently approved and should be actually released very soon to the sites within this next week, actually. So this should be coming very soon. And as I said, it eliminates that one arm. It does move it from a 3-arm to a 2-arm study, which helps in regards to kind of enrollment numbers. We actually added more flexibility in regards to local-based testing. There's a number of issues related to testing, but right now we're allowing any kind of local-based testing, and so that could be from immunochemical testing for mismatch repair protein loss, it can be from microsatellite instability high, the classic PCR-based approach, or from NGS panels would be fine. And then also there's been some adjustments in regards to the use of biosimilars for bevacizumab and some updates to kind of the structure of the protocol. And so I think that's kind of the slide I'm going to leave us on here a little bit about this protocol. And I think the one point to make is that I think this protocol really kind of stems from a real practice change we're seeing. And there's clearly benefits to immune therapy in this group. I think there's a lot of interesting approaches we'll see in the near future of expanding upon the use of immune therapy within this subset of colorectal cancers and other tumor types, potentially even earlier use for us. There is currently the ongoing ATOMIC study, which is adjuvant plus minus atezolizumab for MSI-high resected stage 3 colorectal cancer patients. But fundamentally, the key, I think, is that we have to test all of our colorectal cancer patients for microsatellite instability high or mismatch repair. And that's currently guideline-based NCCN. But that really is the initial avenue into identifying this subset of patients that our therapy really is dramatically benefiting. And so I'm going to stop there and happy to take some questions from the chat or the other moderators.
Thanks. Yeah, we'll also have Dr. Philip, the chair of the GI committee, contribute.
Yeah. Thank you, Michael. That's an excellent presentation. So hopefully it will be opening soon, the study.
Yes, no. So it's very soon to being pushed into metadata rave within the next, I think, next week. We hope that it should be out to sites.
Are we going to have an opportunity to understand why some patients don't respond to immunotherapy?
Yeah, no, I mean, I think it's one of the key questions that we're trying to address at present. You know, it's a small subset of patients, so I think some of the data gathered from the patients that have been treated has been fairly limited. And there's some hints out there in regards to, one would say, your tumor mutation burden level or kind of MSI-ness. It turns out that it's not just the tumor mutation level, but it's kind of how many insertion deletion mutations you have, which are kind of frame shift type mutations. And frame shift mutations tend to be very immunogenic because you're actually shifting your reading frame so you can actually produce not just one amino acid that's different, but you produce multiple amino acids that's different. So you really have kind of a really powerful kind of neoantigen with one mutation to some degree. And so the rate of those appears to have some correlation. And so that's kind of one of the things. There's not been a good delineation of where that threshold is. And it's clearly not in the thresholds that are out there for kind of, you know, a tumor agnostic TMB threshold of 10 or something. It's a very different threshold for specific to kind of MSI high cancers. And so that's one, I think, area that's being explored. I think the other one is kind of one that I relate to a little bit, which is the real simple one, you know, Philip, related to the fact that trying to make sure that the test you have is correct, right? And I think these are tests we've been doing for a long period of time. And so kind of most path labs are using them. And so central use of tests is kind of what's baked into the FDA approvals. But there's always that question about, you know, is the loss complete? How was the PCR? And so in situations where I think there is some uncertainty of the case, I think it's always valid to potentially do two different tests. There's some people that argue that should be more of a standard. I think a screening test with IHC is a great approach for this, or a screening with NGS if you're already getting your NGS kind of based effort is an excellent way to doing it. But I think one of the things that we do like to see is the fact that you do have kind of a high mutation rate, because that's pretty inherent to this type of tumor. Okay,
well, thank you. Just a brief question. In terms of these are metastatic disease. Some patients had their primary removed a year or two earlier, and you can sample, you can use the primary, and some might need to have metastatic disease to be biopsied. And so is there a difference we see between primary and metastatic disease, or we think that all sites are the same?
Yeah, I don't think we have a sense of a difference in the metastatic space. I mean, I think there is some hints that I think are intriguing in the context of the development of immune evasion, right? So MSI tumors are kind of very interesting in the colorectal space, in that we see them in, you know, you would say 20% of stage 1, 15% of stage 2, maybe 10% of stage 3, and then you get to stage 4, and it's, you know, less than 5%. And so what is causing that kind of decline over stage is really this concept of kind of immune surveillance. And so for a tumor to become metastatic, it almost has to escape immune recognition, right? So there is some sense that immune therapy may work better in localized cases. I'm not sure in a metastatic patient whether we see a difference from primary to metastatic site, but I think in a non-metastatic patient, I think there is some real sense that you might have more activity for this type of tumor subset.
I'm going to ask a question which I think is probably important. This is in the chat. Based on the Keynote 177 that you described, we already know that what PD-L1 alone does. Why not atezo plus FOLFOX plus BEV for 3 months, then atezo versus atezo plus FOLFOX BEV until PD? That was a question from one of the audience.
Yeah, good question. I think the study is structured where you can, shift down to a maintenance regimen, right? Drop the oxali as we kind of normally do in a practice, and so you're down to kind of your atezo, 5-FU, and bevacizumab. And I think that's a very, well tolerated and manageable regimen that we do kind of long term in a number of patients. And so I think the idea was that maintenance already kind of established is one that kind of flows with standard of practice. I think the question of, do you need less in regards to kind of initiating immune response potentially for that synergistic effect is a relevant question, but I think a bit unknown. So I think we kind of use the more standard approach where you'd be looking to give your, oxali-based chemotherapy for potentially kind of more around the 6-month time period and then switching to maintenance.
Thank you very much.
Thank you both. Yep, I will thank you both. Please keep an eye out on the chat in case any additional questions pop up. Our final speaker today is Dr. Joe Unger out of our Stats Center. And Joe's going to be talking about some incredibly important work he's been doing regarding clinical trial participation. Dr. Unger.
Yes, hi, can you hear me?
Yes, at least I can.
Thank you. So as Dr. Blanke mentioned, my name is Joe Unger, and on behalf of my colleagues, I would like to present our paper titled When Offered to Participate, a systematic review and meta-analysis of patient agreement to participate in cancer clinical trials, which was recently presented at the ASCO Quality Care Symposium. Next slide, please. I have no disclosures. So patient participation in clinical trials, as we all know, is vital for knowledge advancement and outcomes improvement, yet few adult cancer patients participate in trials with rates estimated around 5%, perhaps as high as 8%. And extensive research has focused on the reasons that patients in particular choose not to participate in trials, which inadvertently or otherwise has suggested, I think, that the burden of treatment decision-making is largely on the patients themselves. Next slide, please. So to better understand barriers to trial access as a system, we previously established this framework about trial decision-making that starts at a cancer diagnosis and the initial physician visit when there is an assessment about trial availability. Then if a trial is available, the physician will then determine whether the patient is clinically ineligible or clinically eligible. And only if the patient is eligible will there then be any consideration, finally, about trial participation between the patient and their physician at the end of this very long process. So my colleagues and I determined in this prior paper that more than half of patients do not have a trial available. And when a trial is available, another 2% are ineligible. So in this context, then, a key question really is, what is the rate of trial participation among patients who are actually offered an opportunity to participate? That is to say, there's a trial available and they're eligible. Next slide, please. You have to click one more time. So to answer this, we conducted a systematic review and meta-analysis, including studies over a 20-year period that examined clinical trial participation in the US. The studies must have specified the number of patients offered a trial and the number enrolled. Next slide. We excluded studies of interventions to improve the rate at which patients agree to participate in trials because agreement rates from such studies are likely not representative. Similarly, we excluded studies utilizing patient navigators to facilitate enrollment to trials and studies that investigated the intention to participate rather than actual trial participation. Next slide. So treatment trials were defined by receipt of any systemic therapy, radiation, or surgery for cancer, whereas cancer control studies pertain to survivorship or symptom management. Studies were also described according to whether patients were treated at academic or community sites, and importantly by race and ethnicity. Next slide. So we conducted a meta-analysis for single proportions using a random effects model, and also tested whether rates of participation differed between Black, Hispanic, and Asian patients compared to white patients. Next slide. So among the more than 3,000 unique studies that we identified, title and abstract review yielded 60 studies potentially meeting our criteria for inclusion. We ended up excluding 25 studies primarily because they included interventions to increase clinical trial accrual or were conducted in a non-US setting, leaving 35 studies comprised of nearly 10,000 patients to be examined. Next slide. 30 studies focused on cancer treatment and 5 on cancer survivorship or symptom control. Most studies were conducted in academic centers, with about a quarter at community sites, and about half of studies were conducted in all cancer types. Next slide. So here's the key results. They showed that the overall rate of agreement to participate if offered a trial was actually 55%. This rate was higher at academic centers compared to community centers. Next slide. Additionally, rates of agreement to participate were identical for treatment trials and cancer control trials. Within treatment and cancer control studies, higher rates of agreement to participate were seen in academic versus community sites, although these differences were not statistically significant. Next slide. Another key finding, very importantly, is that we found no evidence that rates of agreement to participate differed by race or ethnicity. Rates trended highest for Hispanic patients and lowest for white patients. Next slide. So in summary, at least half of patients offered participation in a cancer clinical trial did participate. The findings did not differ between treatment and cancer control and prevention trials, and critically, Black, Hispanic, and Asian patients participated in trials at rates that were at least as high as for white patients. Next slide. So in our view, these results dramatically underscore the willingness of cancer patients to participate in a trial if one is actually offered. The findings also stand in very stark contrast to the commonly cited statistic that only 5% of adult cancer patients participate in trials, which is really a statistic that fails to reflect the many structural and clinical hurdles that stand in the way of trial participation. Next slide. We also found that Black, Hispanic, and Asian patients enrolled at rates at least as high as for white patients, which suggests that observed racial and ethnic disparities in trial participation likely manifest earlier in the treatment decision-making process. The finding also suggests that a good way to improve enrollment of minority patients may simply be to better ensure that they are actually invited to participate. Next slide. So in conclusion, these findings suggest that the root cause of low trial participation rates in adults with cancer is a clinical trial system beset with structural and clinical barriers rather than patient lack of interest. Moreover, the results indicate that differential participation rates between racial and ethnic groups do not seem to be driven by different willingness to participate. So research interventions and policies to improve trial participation really should be focusing more on these systemic structural and clinical barriers rather than an emphasis oriented largely and perhaps even solely towards patient barriers. Thank you.
Thanks. We'll do a couple of questions before we wrap up. One that I see is, do we have data from your trial or perhaps previous trials on differences in participation by race in terms of what's, I just lost it because somebody moved it down.
I think the question was
yeah.
differences about whether they're offered.
Right.
Right. Yeah, I saw that pop up. This was a question that was actually asked at ASCO as well. It's a very critical question. The study was not actually designed to answer that specific question. We didn't include trials based, we didn't include studies about participation based on that criterion. Perhaps without giving it away, that that's our next study in this vein, because I think it's really a critical one that everybody's wondering. And it could be, I mean, that could be one of those upstream factors that does differ by race and ethnicity.
And there's a related question. Do we know of any differences in participation by race in academic sites that are offering it versus community settings that offer?
There was not much difference. In fact, all the way through this, you can see that there was very little difference, no matter how you sliced and diced the data. Now, I would just make a caveat that we only had 5 studies in the cancer control and prevention setting, so the conclusions are a little bit limited there.
Thanks. We do have a couple more, which I'll ask you perhaps to answer in chat later, since I want to wrap up and keep us mostly on time. I want to thank all the speakers. We had just a great mix of topics that really highlights what our group actually does. I want to thank our chairs and our researchers. Of course, I want to thank the GCO and ops staff for, and I really want to thank our attendees. We had some 220 plus people observe these talks, which is pretty great for the middle of the weekend, or middle of the week, work week. So I want to wish everybody a happy new year and hope you do have a great rest of the week. Thanks again.
Thank you.